Okay. Yeah.
Good morning to everyone present here with us today. This is Shriyon from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Anirban Sinha. Sir is MBBS, MD, DM Endocrinology, FACE, Associate Professor at the Department of Endocrinology at Medical College, Kolkata. Visiting Consultant at Amri Hospital, Chairman Ethics Committee, Central Hospital, ASIA Program Chair, MMSc Endocrinology at Textile America University. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is subclinical hypothyroidism. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. And I'm sorry again for all the inconveniences we made because of the glitches in the software. And today I'm talking on subclinical hypothyroidism. And honestly, when we as a clinicians see a patient, lot of time nowadays with the repeat routine tests of thyroid disease and the routine protocols, we see a lot of patients on subclinical hypothyroidism or slightly deranged thyroid function, not so obvious of thyroid levels. So there are sometimes concern or what to do with these kind of patients who are apparently not so symptomatic and how to handle them. So with this, I want to help you out maybe with this talk. So before that, just to define it, TSH is more robust way of defining the hypothyroidism or hyperthyroidism. Sorry, because others have certain fallacies. So euthyroidism is 0.45 to 4.5 TSH. Subclinical hypothyroidism is TSH more than 4.5 but less than 10. And subclinical hyperthyroidism, on the other hand, is less than 0.45. I'm not going to discuss that point today. Maybe start with a case today is that 70-year-old woman is referred with a possible hypothyroidism. She feels well and no major medical problem. Pulse normal, blood pressure is slightly normal or raised. TSH is 5.5, repeat TSH is 6.5, 6.1, free T4 is 1.0, slightly low, and antibodies are negative at the 70-year-old. So what to do with level? Before going to the case, let's start with the definition of subclinical hypothyroidism, that is elevated TSH more than 4, normal total or free T4 and T3 levels, and few or no signs and symptoms of hypothyroidism. These are all we decide how to decide the subclinical hypothyroidism. Among the causes of subclinical hypothyroidism, again, autoimmune thyroiditis is still the most common cause of subclinical hypothyroidism. Then the subacute thyroiditis of other viral disease or other, even the postpartum thyroiditis, post-delivery in the females, that is very important cause of subclinical hypothyroidism. And uncommon causes may be to exclude, to confirm the subclinical hypothyroidism is the mutation of TSH receptor when the TSH is persistently high to maintain the normal FT4 level. And then there is a poor compliance is always an issue on patient sometimes do not mention the medicine, and patient, we see patient is levels are raised, but when repeated inquiry, patient says I'm taking a thyroid medicine later. And recovery from the significant non-thyroid illness, that is a very important factor. So sick patients in the ICU or in the very sick patients in the ward, so these patients may have slightly altered thyroid function that should not be decided as a subclinical hypothyroidism. And patients on drugs like lithium, amiodarone, interferons, sulfonamides, even the sulfonylureas can affect the thyroid function and precipitate the subclinical hypothyroidism. Iodine containing agents, inadequate replacement or overt hypothyroidism, patients sometimes forget to mention. Then the thyroid hormone resistance, these are the differentials of subclinical hypothyroidism. Pituitary TSH HOMA, very uncommon, honestly. All the other causes are excluded, then only we decide that point. Partial thyroidectomy, when the patient has a history, then the patient may have slightly altered thyroid function because of less thyroid tissue available for secretion. And patient has a past history of radioiodine therapy, and the patient becomes getting to overt hypothyroid. Before that, patient remains subclinical hypothyroid because of tissues are destroyed by the radioiodine. Prevalence is around 6 to 8% in the women, mostly 10% over the age of 60, and much less in the men, but it is still there, 3% in the men. Increase in the with increasing age, It's more common in women than in men. Incidences is 2.1% to 3.8% in per year with thyroid antibody positive patients, 0.3% per year in the thyroid antibody negative patients. Why should we care about subclinical hypothyroidism? Because not only the thyroid disease, because the patient is not overtly symptomatic, but certain concerns like cardiac function alteration, altered lipid status, and possibly cardiovascular outcomes are potential concern when we consider subclinical hypothyroidism treatments. Hypothyroid symptoms may not be classic, and then may be associated with altered mood, cognitive disturbance that can potentially be corrected with the thyroid replacement in the subclinical hypothyroidism. And if the patient has a persistently rising TSH over years, then this is likely to progress to overt hypothyroidism. Then we may need to treat the patient. Prevalence of subclinical hypothyroidism, as we have seen in the different studies, is quite high, more than 80 years of age. This is Indian data starts from 8 to 9.5 to certain data goes up to 26% depending on the population they have selected. And what are the concerns with the cardiovascular disease? That has a potential atherogenic lipid profile, and hypothyroidism precipitates a hypercoagulable state, abnormal hemodynamics, impaired endothelial function, and abnormal non-traditional risk factors like lipoprotein A, homocysteine, CRP, LDL size, and etc. So there are difference in opinion in the incidence of cardiovascular disease. Some studies does not find the incidence of subclinical hypothyroidism causing the incidence of cardiovascular disease, but certain other studies, as we can see, 50% of the studies have certain positivity. Middle-aged men and Boston study of 2005, all these shown significant incidence of cardiovascular disease. And what is the potential cycle of thyroid dyslipidemia and CVD? That is overt or subclinical hypothyroidism can present with a hyperlipidemia, alteration of blood pressure, hemodynamic alteration, emerging risk factors of CVD when they are along with, then patient develops endothelial dysfunction and the cardiac alteration, and obesity along with the subclinical hypothyroidism can magnify the risk as well. So this is the lipid effects of thyroid dysfunction. Over subclinical hypothyroidism, the total cholesterol is increased, LDL is increased, HDL is no change, triglyceride is normal to increased, ApoB is increased. So these are potential concern. And thyroid dysfunction also predisposes the individual to become cardiovascular risk factors such as the metabolism and production of adipokines, oxidative stress, and metabolic syndrome. In many cases, hypothyroidism and hypercholesteremia coexist. So whether the treatment can improve it, that is one of the concern. Lipid profile in subclinical hypothyroidism. So it shows that L-thyroxine significantly affect the dyslipidemia when TSH is 10, and in cases when the TSH is 5 to 10 also. So this is significant improvement, and more so when the cholesterol is more than 250, and that is one of the significant concern where we can improve the treatment. And when the subclinical hypothyroidism with the congestive heart failure, we can see follow-up studies, a TSH of more than 10, that is overt increased risk. 7 to 9, there is a slightly increased risk as well. We can see here, even 4.5 to 6.9, we can see there is a certain increased risk of the follow-up up to 5 years. So TSH levels in the patients of prediction of risk cardiovascular disease is there. Hazard ratio of TSH 4.5 to 6.9, hazard ratio is 1, that is no risk. 7 to 9.9, hazard ratio is 1.17, and more than 10, that is over hypothyroid, almost 1.9%, almost twice the risk of cardiovascular events is there. But again, subclinical is a dubious area, but some studies definitely show it also has an increased cardiovascular risk. Treatment, there are certain disputes here as well. Argument in favor of treatment is that potential impact of morbidity, mortality, especially when the TSH is more than 10, possible relation of dyslipidemia, atherosclerosis. Other potential symptoms like low mood, improvement of memory is also significantly improves with the treatment of subclinical hypothyroidism. And osteoporosis is one of the important factor as well. Thyroid requires anabolic hormones to maintain the bone health as well. Against the treatment, there are certain points as well. So there is impact of the cardiovascular morbidity, mortality is not so very clear, especially in the elderly population. So more than 80 years, preferably not to treat if the TSH is less than 7. And data to improve symptoms, mood, cognition of quality of life is very equivocal, if not negative. Some studies shows improvement, some studies no. So it is not a very clear picture to confirm that it caused the improvement of the mood and cognition. TSH may normalize if the TSH is less than 7 and antibodies are negative. So it is more important to treat the hypothyroidism, at least the subclinical hypothyroidism also. If the antibodies are positive, there is a higher risk of progression of autoimmune hypothyroidism and end up in overt hypothyroidism. In that situation, we may require treatment. Cost is again an important concern. And definitely over treatment is a very risky zone. So patient becomes subclinical hypothyroid to subclinical hypothyroidism. That is a concern. Management, there is no clear consensus when the treatment replacement LT4 is beneficial when the serum lipid profile or cardiovascular risk are in the subclinical hypothyroidism. But TPO or thyroid substitution is recommended if the TSH is more than 10, antibody is present, and not so elderly patients. Subclinical hypothyroidism with increased risk of all cause and cardiovascular mortality. There is a very big study. So relative risk of death from all cause mortality CV subjects with subclinical hypothyroidism is 1.3%. That is 30% increased risk. And also CV risk is almost 1.68, almost 60% increased risk. Subclinical hypothyroidism is found to independently associate with the increased risk of all cause and cardiovascular mortality of adjusting the co-founders. So that is, in this important study shows that definitely it improves the outcome, and that is a very big study. Then levothyroxine treatment in the subclinical hypothyroidism, fatal, non-fatal, and cardiovascular events, we can see that two difference as there, 40 to 70 years and more than 70 years. So we can see 40 to 70 years, levothyroxine treatment improves the outcome, but more than 70 years, it actually can sometimes aggravates the outcome, and that is, but it is not statistically significant. So at least it does not improve the outcome. So management of subclinical hypothyroidism with dyslipidemia. So in the dyslipidemic perspective, if the patient has a high cardiovascular risk, then replacement may be considered up to 25 to 50 microgram of thyroid replacement, and TSH should be measured after 3 to 6 months. If the TSH level between 4.5 to 10, routine treatment may not be required initially. If the levels are rising, then we require treatment with the thyroid replacement. A lipid profile is recommended at least 6 months to yearly. In studies, diabetes detected prevalence is 5 to 8% in the subclinical hypothyroid patient. That is one of the important confounders. And there is a higher prevalence of diabetic nephropathy in the subclinical hypothyroidism. So risk of cardiovascular events, again, per se, diabetes independently also increase it. So combine both thyroid and diabetes, increase the hazard ratio to 2.93%, almost 3 times. And then it's in this situation, we may improve the treatment with the thyroid replacement, even in the subclinical hypothyroidism. And there is no normal free to full level was significantly associated with insulin resistance in the diabetic population. So treatment with the subclinical hypothyroidism also improves the insulin resistance in certain data. So complications of diabetes and hypothyroidism, because commonly we see lots of patients have diabetes and subclinical hypothyroidism together. Treating hypothyroidism improves the renal function in diabetic patients. And diabetic patients with subclinical hypothyroidism have more severe retinopathy than euthyroid patients of diabetes. So in this situation, maybe treating early of the patients of potential retinopathy can improve the retinopathy progression in the diabetic patient. Frequent hypoglycemic events are also less with the thyroid replacements. And it is observed that children had the severe diabetes if they have been hypothyroid, and levothyroxine replacement may be beneficial in reducing the symptoms frequency of hypoglycemic episode in the type 1 diabetic patients as well. But progression to overt disease is to be expected in the proportion of the patient who will add the severe risk as well, because type 1 diabetes also has increased risk of autoimmune hypothyroidism. So treatment with the LT4 reduce the HbA1c in the patients of type 2 diabetes. There are data on it. And treatment with metformin and thyroid replacement reduce the TSH level as well. So my personal publication was also there. Metformin reduce the TSH level independently. So low levels of thyroid disease, and metformin also inhibits the goitrogenous effects in the type 2 diabetic patients. And coming to the pregnancy, that is a more important concern. So hypothyroidism in pregnancy around 15 to 10 to 15% in the patients, and over subclinical hypothyroidism is around 13% in the population, and that antibody positivity is around 18%. So in that situation, even in the subclinical hypothyroidism, patient may require replacement. Perinatal outcome, delivery, and the neonatal variables. So with the compared with the overt hypothyroidism, subclinical hypothyroidism almost equally increase the risk of the other complication as is the overt hypothyroidism. In the neonatal complication, ABGA score less than 7, preterm delivery, all these things are comparable, even sometimes higher in the subclinical hypothyroidism population, we can see in the data. So this is the data from NEJM. So children with the women with the high TSH has the ISU score 4 point lower than the control, and children with the untreated mother 7 point lower than the control has been documented. So clinical practice guideline of the hypothyroidism in the adult, they show that individual patients with the TSH level between the upper level of thyroid levels and the 10 microgram should be considered, particularly if the patients have symptoms suggestive of the hypothyroidism and positive anti-TPO levels. So, as I said, anti-TPO is very important, and dyslipidemia, all these factors decide whether we need to treat the patients or not. So, if the patient is anti-TPO positive and the TSH is less than 7, still we may consider treatment. If the patient rising the TSH level in the over years, TPO negatives in the presence of goiter, dyslipidemia, we may consider treatment, especially in the pregnant population. Elderly, TPO negative, preferably not to treat unless the TSH is more than 10. But if it is more than 10, always treat the patient with the, becomes it is the overt hypothyroidism then. Subclinical thyroid dysfunction is a frequent disorders, and mild subclinical hypothyroidism may be linked with the some important risk factors as we have seen, and it can aggravate the other risk factors like diabetes, cardiolipidemia, all can aggravate the situation. So patient with the subclinical hypothyroidism definitely increase the risk, especially if it is closing to TSH around 10. But elderly patient with even with the TSH more than 10, we need to treat, but less than 10, we may not treat because outcomes are not so very important and clear. With this, I end my talk here, and any question is welcome.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you like to take that up.
Yeah, sure.
So the first question is, what are the key point patients should understand about their condition and its potential impact on their health?
Can you repeat the question once more?
Sure, sir. The question is, what are the key points patients should understand about their condition and its potential impact on their health?
See, the subclinical hypothyroidism, by definition, patient does not have significant symptoms, may have some vague symptoms like low mood, memory disturbance, malaise, body ache, and these vague symptoms. And if the patient, as I said, patient has other factors of risk, other potential risk factor of cardiovascular disease like diabetes, dyslipidemia, family history of cardiovascular disease, and the patient is less than 70 years, it is better to treat, and especially the TPO positivity requires a treatment. But in the pregnancy, situation is different. It is always better to treat if the TSH rises more than 4.5 and the TPO antibody is positive to avoid the complication of pregnancy and the neonatal complication as well. Okay.
Yes, sir. Thank you, sir. The next question is, how often should thyroid function test be repeated in untreated and treated patient?
If the patient has a routine screening, yearly thyroid is good enough. If the patient is on treatment, at least 3 to 6 months interval, thyroid should be repeated because there is a different sessions in the different time of the year may require a different metabolic activity of the body, and requirement of the thyroid hormone may differ. So in potentially we need to repeat at least 3 to 6 months interval if the patient is already on stable dose. But in the pregnancy, it is maybe monthly requirement because rapid titration of dose is required in the serious situation like pregnancy, or in the poorly moribund patients, or maybe patient requiring up titration of the doses. Otherwise, then it is usually 6 weeks, and otherwise 3 to 6 months.
Thank you, sir. There is one last question.
Yeah.
When should treatment be initiated in patient with subclinical hypothyroidism?
I gave you the clear guideline, maybe that these patients who are having the TSH around 10 or rising tighter, past history of CVD risk, or the family history of CVD risk, or the patient has dyslipidemia and diabetes, patient need to be treated. But in the elderly patient, TSH around 6, less than 7, and the patient has no significant complaint except vague move, we better not to treat, but we need to follow up them closely every 6 months. Maybe if the rising titer of TSH, we may try to treat them to improve the symptoms or not. Okay.
Thank you so much, sir, for answering all our questions, sir. Before concluding, sir, any last remarks from you?
Not really, but as I say, this is a very common problem we see day in and day out. And sometimes patients are over-treated, and that thing should be kept in mind, at least in the elderly. Better not to treat, because patient, if they becomes hyperthyroid, there is a chance of arrhythmias in the elderly patients. So that preferably should be avoided. And unless absolutely necessary, better not to treat in these situations if you don't find any advantage over not treating the patients. Thank you very much.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session.
Yeah,
Thank you.
thank you.